The other type of medium-sized vasculitis is Kawasaki disease. Kawasaki disease is an uncommon systemic vasculitis disease affecting mainly children under the age of 5. Kawasaki disease is a medium-sized vasculitis. Kawasaki disease and Hinoch-Schönlein purpura are the most common primary vasculitides in children. It is more prevalent in Asians and native Pacific Islanders and is a leading cause of childhood acquired heart disease in developed countries, which include coronary aneurysms. The exact cause of Kawasaki disease is unknown, but clinical and epidemiological data support an infectious cause. In Kawasaki disease, an intense inflammatory cell response develops in a wide array of organs and tissues in medium-sized arteries such as the coronary arteries. The pathophysiology of Kawasaki involves monocytes, IgA antibodies, neutrophils in the acute setting, and cytotoxic T cells. These guys all play a role in the inflammation of the medium-sized vessel. What is thought to drive this temporary vasculitis is an infection. Theories include Staphylococcus and Streptococcus species, such as from strep throat, and even a viral infection. Antigen-presenting cells will pick up these antigens and mount an inflammatory response. The inflammatory response somehow misdirects the attack and will attack the medium-sized vessels temporarily, and this includes the coronary arteries. This response can damage collagen and damage elastic fibers in the vessel walls and can lead to loss of their normal structural integrity. Despite the repair that occurs, the disrupted structural integrity results in ballooning or aneurysm formation. The clinical features of Kawasaki is usually a child less than 5 years old with high fevers for more than 5 days and irritability. Some classic findings in Kawasaki can be remembered with the abbreviation CREAM. C is for conjunctivitis, bilateral non-purulent. R is for rash, polymorphous or maculopapular rash. E is for erythema and or edema of the hands or feet. A is for adenopathy, lymphadenopathy, specifically in the cervical chains. And M is for mucous membrane changes, which include red tongue, strawberry tongue, and dry, cracked lips. The diagnosis of Kawasaki is made if the child has 4 of the 5 following letters in CREAM, as well as having a fever for more than 5 days. For children who present with a purpura or a petechial rash with fever, the differential is broad. A good start is to divide differentials into thrombocytopenia and non-thrombocytopenia-induced rash. But some important differential diagnoses to remember include measles, where there is evidence of exudative conjunctivitis, Koplik spots, and rash, which tend to occur in the head and migrate to the trunk. Drug reaction is an important differential, which leads to a generalized rash eruption all over the body, usually itchy, and another important feature is the angioedema, which is swelling. Infections is a fundamental differential and includes Streptococcus infections. And remember, infections are associated with the development of Kawasaki. So for example, Streptococcus pharyngitis. And Streptococcus pharyngitis can then also lead to scarlet fever. Streptococcus pharyngitis can also lead to rheumatic fever, an autoimmune response to the Streptococcus infection. Another differential are the Staphylococcus infections, which typically include the skin, and is also associated with the development of Kawasaki disease. Staphylococcus infection differentials include Staphylococcus scald skin syndrome, which is characterized by red, blistering skin that looks like a burn. Another is toxic shock syndrome, which is caused by the release of bacterial toxins from the Staphylococcus species and is associated with tampon use. Another important differentials and also potentially the trigger for Kawasaki are viral infections, which can also manifest as a maculopapular rash. Finally, a very life-threatening differential is Stevens-Johnson syndrome. Investigations to order include a full blood count to look for signs of infection, EUCs for kidney involvement, LFTs to look for viral causes affecting the liver, CRP and ESR, which are inflammatory markers. These should be high in Kawasaki, as well as in infections. Urinalysis is good to look for evidence of increase in white cell count. Finally, it is suggested that an echocardiogram should be performed once the diagnosis of Kawasaki disease is made, as well as 6 to 10 weeks after, to check for myocardial inflammation and coronary artery aneurysm formation. Remember, the main complication of Kawasaki disease is coronary artery aneurysms, but it is not uncommon for aneurysms to occur anywhere along the branches of the aorta. Once diagnosis of Kawasaki is made, it is essential that a pediatrician is involved. Admit the child and commence immunoglobulin intravenously as well as aspirin. Commencing intravenous immunoglobulin within 10 days of fever onset has shown to reduce cardiac complications. The complications of Kawasaki are mainly cardiovascular and include coronary artery aneurysms, as well as artery aneurysms anywhere else, myocardial infarction, pericarditis, and myositis. Thank you for watching. That concludes the video on medium-sized vessel vasculitis.